Hello and welcome. And today I'm going to talk about AMC Clinical and how to pass the history station. Now, history is very important, and I will highlight to you first about why is it important in terms of specifically the history taking stations, why the history stations are predominantly the bread and butter of any exam, including AMC Clinical. But before I do that, I want to go back a little bit and I want to talk about AMC Clinical. Now, it's an important exam, and I think it's important for several reasons. Now, before the current availability of exam dates, which are more now in-person exam dates, which I tend to prefer compared to the online exam dates, uh, it was COVID time, and people were predominantly doing their exam in an online exam format, and it was okay. It was a bit glitchy. Some people had good experiences with online exam format that they thought that in compared to the in-person exam, online exam has got a pass rate. I don't know about that. It might be true for you, and if it's worked for you, definitely. Having said that, I think the AMC clinical exam is more important today than it was before. A, because the fact when you pass the AMC clinical exam, you're already belonging to the top 30% tier. The things that you actually learn whilst preparing for the AMC clinical exam are the things which are important for your practical knowledge, like working on the floor, working in a hospital system, working in a hospital, in a GP center, because some of the cases are really based around the primary care that we provide in a GP setup. The other thing which is more important is that it it is not only important from the recruitment point of view and from the point of view of work, but it is also important to realize your overall career trajectory. So those of you who are thinking, though, look, I would be able to get into a WBA program, it might not be that easy. First of all, when AMC introduced the WBA program, it was to assist those regional and rural hospital who were having significant amount of trouble recruiting the doctors. Now the scenario is completely different. There's so many applications in rural and regional settings. The doctors are spoiled for choice. In fact, the hospitals are spoiled for choice, not the doctors, sorry. Hospitals are spoiled for choice. If you apply to the WBA program, first of all, it would be very difficult to score a WBA position. Um, Even if you end up joining the hospital which offers the W program, they would already have a waiting list of at least 12 to 18 months. So the doctors who are already working there would be given a preference compared to the doctors who are freshly joining. So it is already putting back you or pushing you back at least 12, 18 months ahead. Um, uh, in the wait list. So it might not work out in the global scheme of things. You have to do AMC clinical scenario if your hospitals are, and you can't be very choosy about the jobs that you get. You get the jobs which are available to you. So if you're doing the jobs which are in the hospitals which don't offer the WBA and your job contract is about for 1 year, are you going to just miss that 1 year of clinical work and not attempt AMC clinical 2 and hoping for a WBA position to come back? That's a lot of year lost. You're actually let go of your general registration for another 12 months leading up to 24 months. So that's why I think these are the three more crucial things. That don't bank on WBA exam. Think about AMC clinical exam. It will give you general registration about 12 months. You can join the specialty training or GP training after the full registration. You start working as a locum, which pays very good, and you can mix and match. Plus, the other thing, as I said, it prepares you for everything: hospital job, GP work practice. So it's a very well-rounded approach. And plus, when you pass the AMC clinical exam, it pretty much brings you at par with the Australian medical graduates. So you belong to that top 30%, what I say, of doctors who have got recency, who've got completed CPD activities, and plus who are able to, you know, demonstrate by virtue of passing the exam that they are actually quite righteous doctors in terms of the skills and knowledge. Now, for the sake of this presentation, I'll just bring up the presentation that I've prepared in terms of history taking, that why the history taking is very important. So I hope everybody can see the screen. Just before anything, look, our AMC clinical course is starting soon on 1st May. The website is inviting registration, and we've made it simple. I'm very glad that our course are now completely refreshed from the point of previously. Lots of candidates used to ask me, when is the course? Is it, what days of the week it is? And we had random days, but we not simplified it. It's every Monday and Wednesday, two groups. The morning group is 10 a.m. to 1 p.m. Sydney time, that is, and PM group is 7 p.m. to 10 p.m. Sydney time again. Um, you've gotten access to the portal, and the portal has got all the notes, it's got all the slides, it's got videos, it's got guidelines, it's got everything. And the portal has grown significantly from all the courses that we've been doing for the number of years. All of the courses are uploaded on the portal. And if you're joining our course after conducting your live session, if you could not attend that session for some reason, the video of that course along with the slides would be uploaded to the portal within 24 hours. So you can access that information. Now, why is our course now different? We've got lots of new tutors. We've got Dr. Hira, Dr. Zoe, Dr. Tenzin. Some of you who are joining this session may already see them. And we've also got Dr. Nal, who's a very senior emergency physician. He's a very passionate teacher. So we've got good things going on from the tutors' point of view. And Dr. Hira and Dr. Zoe seem to be very popular, running morning and Dr. Zoe also some evening sessions. The other thing is we completely redefined. We've freshened up the scenarios, the new cases. So it is more in tune with the modern times. So you're not missing out on anything. This is one-stop shop where you get to prepare, you get to role play, you get to get critique and get that feedback and start the learning process. So do register if you're interested. Next thing up, if you want to contact me about anything, that's the best contact, info@emergencyfocus.net. Now, I'm going to keep it very simple. I'm going to talk about the history, why is it important to pass, and I want to talk about three things. I want to talk about the strategy, I want to talk about key points, and then we're going to discuss the cases and highlight that strategy and key points and how it works in terms of those cases to help you maximize your stations. Now, history is important because you will get about, I think, 8 to 10 stations, which almost is a passing number from history point of view. Now, history can be asked independently. That take the history. This is the patient who's come with chest pain and come up with the differential diagnosis. So it may be asked independently, which is seldom the case, or may be asked in a combination of physical examination. It may be asked in the a combination of generate some diagnosis, working diagnosis, differential diagnosis. What about the management? And sometimes it may be coupled with counseling that, look, this is the history. This is what you're suspecting. Can you please counsel the patient in terms of having a Down syndrome baby or suspected trisomy? Or there's a malignancy, which is a picture on show, and can you counsel the patient taking some essential information? So, how do we go about it? Like, I've got a very simple approach. I'm going to talk about the steps of the history taking. Whenever you start thinking about the history station, say for instance, you've got a history station, always start in your mind with a set of differentials. What I mean by that is when you generate differentials in your mind, you're actually telling yourself cognitively that these are the questions in terms of differentials that my history is going to be focused at. Because you've got to play the game in AMC. The game is that you are going to get the scenarios which are time capped. So it's not that you got unlimited number of time and you are going to do the scenario. It is all time capped. So you need to be very efficient in terms of what you are asking for the questions. So generating those differentials will help you pinpoint and focus those questions to come up with the final completion of the task. So read the task, read the question, come up with your differentials in your mind. Number two, what I call is ICCF approach, that introduce yourself, check for the comfort and analgesia, check for the confidentiality, check for the stability patient, and move on. All right, don't waste much time in that space. Now, the history can be either asked in a full format, that this is a complete detailed history, or a focused format. That tends to be more the case now when you're doing a physical examination, when you're doing a management, take a focused history, no clinical examination required, no further management required, just come up with the differentials and the working diagnosis. So you've got to make a distinction very early on that this is not a full detailed history, it's a focus history, or it is a focus history, not a full detailed history, because that will save you very crucial amount of time. Now, I always say you've got to play the game. And the game here is when you're talking to the actor, asking the question, is start off with an open question. That is non-leading question. Tell me what brings you here. I'm so and so. I would like to know more about your condition. Can you tell me that? And that sort of tricks the actor in giving you all the information that they have got available. And then finer bits or more minutiae can be trickled out with some leading questions. So it's a combination of both leading and non-leading question, which is built on differentials. So what we've talked about, number one, set a differential, get away with the introduction and rapport building, come up with an open history approach, and then narrow it down with the leading questions so that you're not missing anything. All right. So I will actually I like to display this history slide at the end or at the beginning of every course, and I think it just makes a lot of sense. So I always encourage the participant to read the task first. So like the task of please take a history, please conduct the examination, please explain the management, come up with the differential diagnosis, and so forth. By picking up the task, you're actually optimizing your time. So read the task first, and then after reading the task, read the question, plucking that information in the question as relevant task is. Whether this task is about history, whether this task is about counseling, whether this task is history plus physical examination, history plus counseling, history plus management. So be more efficient. And at the end of that process, that cognitive process, come up with differentials, come up with some sort of output in your mind. Now, the next 8 minutes, when you're actually inside the station, you start off, as I said, ICC approach. Introduce comfort, consent, consability. My name is so and so. I'm here to ask you some questions about your pain, problem, whatever it is. And can I just ask if you have got any discomfort right now and offer you some analgesia? Consent, obviously, if it's a confidential issue, psychiatric history, your abdominal examination, young, minor, or vulnerable patient, start off. Do you need to have any patient that you need to have a chat to me about? Okay. And then we go on with that. Okay. So just as in, as I was saying, that by taking this approach, you're actually developing a rapport early on. Finally, you move on to the history, a specific examination, specific investigation, a specific diagnosis and differentials management and summary, what I call a squid approach. Summary, invite questions, give them the information, hand layout, and danger sign, squid approach. So how about I highlight this by the way of an example? So this is an example or of a full history taking. So this is Mrs. Reagan, 72-year-old lady who's presented to the hospital with 4-day history of left-sided toothache and mandible swelling. In the last 2 days, she has noticed a lump develop on the left side of her face, and it is extending toward her neck. It should say her neck. Anyway, the lump is painful. The vitals are tachycardia, temperature of 38, blood pressure of 110 by 80, and saturation of 99% on room air. My tasks are to take a history from Mrs. Reagan. Please inform Mrs. Reagan about the diagnosis based on my history, positive findings. No examination required. So basically, as I said, we start off by taking or reading the task, take a history. So I'm telling myself that I'm going to, when I'm reading the question, I'm going to be taking the history. Okay, number one. Number two, I am going to be explaining the differentials and the diagnosis. So I start off with, as I said, reading the scenario. Okay, this is a 72-year-old lady who's presented to the hospital 4 days. Okay, I'm highlighting and flag posting the main thing: left-sided toothache, mandibular swelling, 2 days, worsening swelling, and left side of the face and extending. All right, perfect. So I've got some sort of infection going on. Most likely it's an infection involving the lower jaw. It could be mandibular infection. It could be tooth abscess. It could be facial cellulitis. It could be malignancy. The different men. So without even taking the history or start engaging in that process, I've got 3 differentials in my mind already. It's a tooth abscess or a dental abscess. It's a facial cellulitis with an underlying soft tissue swelling or abscess. Brilliant. Or it could be a malignancy, but then I need to establish these points. So how do I start that? I start that with questions. So the question that I'm going to ask are that I'll start off typically as I'd start off. Ms. Reagan, my name is Dr. Rizwan, and I'll be looking after you today. Now, as I believe, Ms. Reagan, that you have got a left-sided facial swelling and pain and toothache, can I offer you some pain medications? And then a stability check is already there. She's hemodynamically stable and not compromised. Now, what did I say about the open-ended question? That's where I'm going to jump in. And this is the trick that you're going to play in AMC clinical exam. Now, Ms. Reagan, can you please tell me about your problem that brought you to the hospital today? By asking that question, you're actually trying to extract all the information that is available to come in front of you. So the actor which is trained to be Miss Reagan in the exam, they have to give you as much possible information that they can without you aligning yourself with the Socrates approach and you taking their job. You're getting them to do their job properly. Okay, so you start with the open question and give the actor to speak for at least 2 minutes. Okay, that's completely fine. So role player instruction, what were they designed to say? So Mrs. Reagan says, look, I've had left-sided toothache for about 2 weeks. So I went to the GP And he prescribed me some Panadol and ibuprofen because swelling is not bad, and he's referred me to dentist. Now I've booked an appointment, which is the end of the next week, but today the toothache is significantly worse, and the swelling also in the last 3 days I've noticed has been gradually getting worse, and you can see my face is all puffy and red. And since last night, I've had some pus coming out there, doctor, and it's very difficult to eat properly because any movement of the jaw causes significant amount of pain. All right. Okay. So you've got all that information about the natural history of progression of the disease. Now you focus it with your leading questions. Now, Mrs. Reagan, you said something about pus oozing, almost like a lawyer, like you questioning. Now, you said something, you actually nitpicking on the information which was given to you. You said something about pus oozing. Has there been any bleeding from the wound? So, what are you trying to imply or rule out? Is there any vascular structure nearby? Malignancies, in particular, are very vascular. Face is actually very vascular. Because if there's bleeding, then I've got another problem at my hand. So, you're trying to rule that out. What color, smell, and discharge had it been? What are trying to highlight? Could this be an anaerobic growth? Because if it's a tooth abscess, there are a lot of anaerobes there, and then it will help you, choose the correct antibiotic. You may be adding some anaerobic cover like metronidazole. Now, you mentioned some headaches. Again, working like a lawyer. Can you tell me more about the radiation? Has there been any particular problems like vision or speech issues, or any other things in terms of confusion? Now, why is that important? Because it is a facial or neck abscess. Could there be an extension into causing meningoencephalitis? Could there be a headache because of completely separate reason? If it's malignancy, which is one of the differential, could it be a secondary brain spread? So that is just a quick tick that you're going to you know follow. Now, when you're on the page of malignancy, ask about the constipation symptoms. Has there been any loss of appetite? Has there been any weight loss? Have you noticed any lumps coming on your neck or anywhere else in your body? Now, the other trick question which I would like you to now focus on is focus on red flags. So we are in that leading question territory. We've asked the open-ended approach. Now we leading question territory, red flags. Now you said that you've had some difficulty in chewing due to pain. Have you had any difficulty swallowing? Has there been any difficulty breathing, in particularly with any positioning? So basically what you're trying to highlight is any aerodigestive compromise. What about the fever? Tell me, have there been any associated shivering, rigors? Have you been feeling dizzy, lightheaded? Have you had any pre-syncope or syncopal events in the last few days since you've been having that infection? Again, the answer was no. Now, you mentioned, Mrs. Reagan, that you've got an appointment with dentist. Let me ask you by that, asking that have you had previous similar kind of problems, like dental infections or recurrent infections? And the patient says, yes, I've had a previous dental abscess, which was treated with oral antibiotics. So there's always almost no harm in asking the patient, have you had this kind of problem before? And I would encourage you to include that in every part of your history taking. Have you had this kind of problem before? This is crucial, because if she says yes, then you've got an issue that you established that this is a recurrent theme. Okay. Now, moving on. Now, when I was working as a registrar at St. George Hospital, one of my mentors told me when I was preparing for fellowship exam that you need to be efficient with the time, because exams, OSCE in particular, are race against time. So in terms of taking the history from the past medical history, the drug history, and allergies, you just mix that into one question. Now, Mrs. Smith, I'm going to ask you something about your past medical history and medications. Can you please tell me if you're taking any regular medication and for what reason you take those medications? So then the patient will tell you, oh, I'm taking, the patient actually, this patient tells you, I'm taking prednisone and methotrexate and hydroxychloroquine for rheumatoid arthritis. I've also got asthma and I've got type 2 diabetes, for which I have been taking oral hypoglycemic. I'm not on insulin. So then again, instead of asking past medical history and medication history, you've mixed and got that information in half the time. Now, have you got any allergies, in particularly any allergies to any antibiotics? No. And what's your social history like? I'm a retired school teacher. I don't smoke. I don't drink alcohol. Perfect. Moving on. So now, organizing all of those information in my mind, I've established that this is a patient who has got obviously a dental abscess. with facial cellulitis, it looks like that it could be a recurrent thing because she's had it before. Plus, she is immune compromised because she's got rheumatoid arthritis and she's that immune modulating drugs like prednisone, methotrexate, hydroxychloroquine. Plus, I've also established that she's got no red flags of imminent decline or collapse, like aerodigestive compromise is spreading into the neck, into the peripheral, Ludwig's angina, in terms of airway compromise, none of that. So I have established a lot just by being very focused. Moving on, what do we do next? So my final diagnosis explained to the patient is facial abscess from an underlying tooth infection. It could be cellulitis, not an abscess, but it's pretty hard to beat that because you can see that there is extensive amount of swelling onto the face along with the abscess and pus oozing out. Or the other differential, whenever you're talking about the recurrent infection, always include, especially when you're dealing with cellulitis, underlying osteomyelitis. When you're working in the hospital, you'll see patients with cellulitis of the lower limb or upper limb or any other part of the body, and the X-rays are required to rule out any underlying osteomyelitic changes on the X-ray. So overall, as I said, I've established everything and come up with the differentials, and I can explain to Mrs. Smith based on the history. So the way that you explain to the patient is that based on the history and the key findings in the history, what I believe is what you've got an infection around the face with a pus collection, which could be coming or originating from underlying tooth infection. This is because you've been having some toothache, and that toothache would be the start of infection, which is now spreading and giving you all that swelling. And now, because this infection is not treated, it has become pus. Now, the reason I think that this is very important for us to treat and act upon it right now is because you have got immune compromised condition with rheumatoid arthritis and you're taking medication which weakens your immune system. All right. So this is my diagnostic commentary that I'll give to the patient. Now, do you have any questions? Not that it's a part of task, but I'm still doing that as a part of repo, which is throughout the part of communication skills of that scenario. So, examiner who's sitting there uh, across the table had this in their critical errors list. Not established the patient's immunocompromise. Well, I've established that. I've extracted the information. The patient's been having recurrent infections, has had previous dental abscess treatment, oral antibiotics. The patient has been taking hydroxychloroquine, methotrexate, and prednisone, has got diabetes. So I've established the patient as immunocompromised. Also, at my end commentary, I've actually explained that her immune system is weak. So I've actually ticked off that point. Not considering osteomyelitis, I have mentioned that in part of my differentials that I was thinking that you may have an osteomyelitis because it's a recurrent infection. Sometimes infections don't clear away, and we deal with the conditions called chronic osteomyelitis, which is treated separately with PICC lines, long-term antibiotics, and so forth. And not considering the abscess formation. This is something which we established on first slide, that there's a large swelling collection with an underlying pus oozing. So abscess was one of my main working differential. Now, what about the focus history? So let's just rejig the whole scenario. If the scenario is mixed with, let's read the task first. Take a focus history. So that is my cue here. Take a focus history from Mrs. Reagan. Explain the diagnosis, task number 2, to Mrs. Reagan and outline further management plan. So I've not only got to explain the diagnosis, but also the management. But the the examiner wants me to actually now be more economical in history taking. Okay, so how do I do that? Again, the same information. I've got these cues that I have to take a focus history, conduct, tell the diagnosis, Miss Reagan, and outline further management. Now, let's see how the scenario has been modified. Again, 72-year-old lady presented in the hospital 4 days with left-sided toothache and mandibular swelling. Last 2 days, noticed lump, left side face, and extending towards the neck, which we see there very easily. The lump is painful. She has had a facial CT, which confirms the dental abscess. So that's now as an additional information available now that she's had a facial CT, which confirms the dental abscess. So it is actually helping me the diagnosis already. The diagnosis is already there. And plus, I've got an image here which shows that there is a dental abscess formation. So how I'm going to address that? I've got 3 tasks to complete instead of 2 tasks from the last scenario, which was a full history and explaining the diagnosis. I've got also need to outline. So here, my job is not that easy, but actually a little bit tough. So again, I have come up with the differentials with a confirmed diagnosis, which is on CT. But still, I've got some differentials that it could be osteomyelitis, which cannot be, which could be something which I need to consider. So I again start off with the same introduction. Mrs. Reagan, my name is Rizwan, and I'll be looking after you today. Now, I believe that you have a right-sided face and toothache, and for that, you may need some painkillers. Do you want me to have you given some analgesia? And then you obviously check for the stability and confidentiality. Now, open questions. You still start with open-ended question because that's still a part of the focus history. Okay. So now, Ms. Reagan, you have to tweak your response a little bit. I know that you've had a CT scan of the face, and I would like to explain the diagnosis which we established in the CT scan. And plus, I would like to offer you further management. And is there someone with you or you by yourself? So I'm actually mixing in all the information which is available to me in the context of the CT scan, and plus developing a rapport by taking any notes that if there's a patient who would like to have any other relative or friend at the same time. So the patient says, no, doctor, I'm quite okay. I would like you to tell me the diagnosis because I've had this toothache for about 4 weeks. I went to the GP. He's been giving some Panadol and Nurofen, which is not really helping. And hence he referred me to the dentist. But the dentist appointment was quite far away. The toothache was not really improving. So the GP organized for the facial CT scan today. And after the results came through, that my doctor asked me to go straight to the hospital. The swelling has actually gotten worse in the last 24 hours. And now I've got pus discharge coming out and I'm unable to eat properly, as any movement in the jaw is causing a significant amount of pain. So that was my open-ended approach, which the patient just completely sort of confirmed that history which I needed to establish. What about the leading questions? I'm now going to again do that lawyer work, that nitpicking, that, oh, you said pus oozing. Um, has there been any bleeding or blood from the wound? Um, that's very important because, again, as I said, vascular structure. What about the color and smell? Anaerobic growth, as I said before. Any other symptoms like headache, neck stiffness? Could it be an extension through the neck planes, retropharyngeal abscess, Vincent's angina? Could there be an aerodigestive compromise in terms of swallowing or imminent airway compromise? No, none of that. Have you had this kind of problem before? Yes, I've had dental abscess before, which was treated with oral antibiotics. Now, again, I think we still have to establish the recurrent and immune compromised state. So I'm going to ask, can you tell me what medications you take regularly for what condition? Again, the patient gives me the same information. I'm on prednisone, methotrexate, hydroxychloroquine for rheumatoid arthritis. I take oral hypoglycemic medication for type 2 diabetes. Perfect. That is my focus history done. I would ask about quickly if she's got any allergies, because obviously if the part of management involves giving IV antibiotics, I need to know about the allergies. So now the part two, which is explain the diagnosis. Now, very simple words, because I'm explaining the diagnosis to the patient. I need to be very economical and very simple in my word approach. Now, Mrs. Reagan, the CT scan of your face confirms the diagnosis that you've got a left-sided facial abscess, which means that the facial swelling is due to the pus collection underneath your right lower jaw. The condition which can happen more likely to happen in a patient who have got weakened immune system, which in your case is because of the medications that you take for your rheumatoid arthritis, like methotrexate, hydroxychloroquine, and prednisone. Plus, on top of that, you've also got diabetes, which makes you prone or at risk of having recurrent infections. However, I don't think that this infection is spread um, to any other part of the body, and it does not appear that we need to be worried about any airway compromise or any, compromise of swallowing. So my management, I always say that whenever you're managing the patient, make sure that your clinical priorities are coming forth. Think about the referral pathway first, because definitely this patient is going to require incision and drainage. So you refer, I need to contact the maxillofacial or surgical team to discuss about the admission, because you're going to require, an operation to have this pus drainage, pus collection drained. Okay. In the meantime, I'm going to start you on antibiotics. My choice of antibiotics is going to be benzyl penicillin and metronidazole to help prevent the further infection. You don't have to say the name of the antibiotics, but you can say that I'm going to start you on some antibiotics through the vein. Don't say intravenous. Be very casual and very layman in your terminology. I'm also going to prescribe you some regular painkillers, because obviously, as I appreciate, this is a very painful condition and Panadol and Nurofen have not helped you. So I'll start off with some stronger painkillers. Now, I want you not to eat and drink anything. And for hydration, I will start you on some fluids through the drip. Okay. We'll also monitor your condition. So if there's any deterioration in your condition, or if you know anything differently, like if there's any breathing difficulty, if you're having fevers and rigors, please let me know. And uh, in the meantime, what I'll also do, I'll send for some baseline bloods, inflammatory markers. I'll take some blood cultures, and I'll take a swab of this sample of pus coming out and send it to the lab so that we can identify what bugs are causing that infection. Perfect. Well done. Now, end off that task by asking, do you have any questions for me? Okay, so that's squid approach. Summarize. So in summary, I believe that you've had this problem before. This time, this problem has obviously caused significant deterioration. Now it's a pus collection. This problem is because that you have got a weakened immune system because of diabetes and rheumatoid arthritis, for which you don't methotrexate. What we need to do right now is to start you on some, I need to refer you to on surgical team, because they need to operate or do this procedure to have the pus drained out to prevent the infection from spreading further. And in the meantime, I'll start you some antibiotics to the vein. I don't want you to eat and drink. I'll start an eye fluid. So basically summarizing to make sure, have you got any questions for me? So after you summarize, okay. And in the meantime, if you've got any problems or any issues and you think about any questions, please let me know. So you're coming across very natural, very organic when you're presenting that information. Okay, so let's see what the examiner had in terms of critical errors. Not explaining the diagnosis of dental and facial abscess. I did that. Not giving intravenous antibiotics. I did that. Not referring to the surgeon or maxillofacial surgeon. So you see that I have again ticked off all those points. So I'll get Dr. Hira now to discuss some of her cases, which she will do. But the point that I want to make here is that whenever you're discussing the cases, especially the cases of history, which might be mixed with the examination, which might be mixed with the giving the differential diagnosis plus the management or counseling, be very smart with your approach. Try to take history in as a summary, open way. After introduction, analgesia, open questions. Try extract or get the actor to give as much information as they can, and then tease out the information with leading question. So open-ended approach, leading questions. And then as a part of the leading question, go through all the little issues of the history which are crucial: past medical history, drug history, allergies, social, sexual, all of those bits and bobs. And at the end, exclude the red flags in the history taking: any aerodigestive compromise, any difficulty sleeping. Have you had any syncope or presyncope in that particular case because of the spread of infection? So that makes your history very economical from the time point of view. You're not really stuck in, because I think as a common mistake that we do as doctors is that we talk about Socrates' approach, and sometimes not everything mixes with the clinical scenario in particular, and that can somewhat upset the examiner, and you might not be able to extract that information in a timely way. This is a much more time efficient manner. I hope you like it. I'll get Dr. Hira to discuss some of the cases, and I'll leave it at that. Thank you very much, and we'll catch up later.
So just on a lighter note, the patient comes to you with this much of the information. So it's our job to extract all the relevant piece of information and build up our case. All right. So what a few 4 or 5 important points that I think I came across when I was a candidate appearing for AMC Clinical was that history repeats itself. It's pretty much the same thing as Dr. Zwan said. Do explore and think from the scenario, get that vibe and feeling. Is it something which is acutely presented? What is the setting setting the patient has presented in? It might be a GP setting or emergency department. Do you think that this is something very dramatic and drastic that happened over a few minutes or a few hours, or has it been going for some time? That would help you to delineate the differentials in your mind when you're thinking of that problem for which the patient presents. The other thing is that start from scratch always, and you will get your match. This is basically, again, another way of saying starting with the open-ended question. So what is the scratch? It would be the presenting complaint the patient has presented. In a very layman language, they present with some kind of pain, swelling, fever, some discharge, something like that. And then be very open about it. Let the patient speak for 40 to 50 seconds or maybe a minute. They would volunteer some very important piece of information. And eventually, when you ask some direct questions, you will get your match of your diagnosis. The other thing is to play smart and act fast. Whatever the piece of information has already been shared, don't try to reconfirm and retell it that, because obviously they are there to test you, not to challenge you on something. So play smart, devise your questions. Once you have some relevant piece of information, you direct yourself to a system or two, then act fast. Try to extract as much of the information in 4 to 5 minutes of time. That is a very ideal time to collect as much history you want to, because after that, you are in a good position to handle the other tasks that are mentioned along with the history. Then explore what is more. It's good to have an overall, a general view, general approach to a patient, showing more of empathy, making the patient more comfortable, letting the patient volunteer more and more information, but don't just waste or divide your time on the things which are not quite very directly relevant to the case presentation or the presenting complaint. So try to explore out the presenting complaint or the problem and explore it more rather than touching each and everything. I would exemplify it. For example, a patient who has problem A, and he is a smoker, he's a drinker, which are not directly as a precipitating factor or risk factor for the problem A that he has presented. You can address that in a line or two, but don't just put all your energies on doing that counseling and addressing those issues which are not very quite relevant at this moment of time.
That's a very common point. Actually, it's a very common trap because we tend to waste a lot of time in those unnecessary. We tend to follow the Socrates all the way up to the upteenth detail, which is fine, but you need to be efficient around it. As I said before, that if you're not really, and that's the common mistakes with most of the doctors make. They just go on stout. I need to check every bit and detail of Socrates, not realizing that you've got a time race against time.
That's right. And then obviously everything falls in place if you have a solid theoretical background. I mean, the differentials would come to your mind, the important questions would come to your mind only if you have something in the jar you can add on to it. Otherwise, devising your questions at that time, thinking of your, recollecting your thoughts and everything, that would just simply put an extra pressure and would cost you a case or maybe, just consume all of your time. Role of mnemonics. This is something as a student, I think it works always. It saves you time, it saves you energy. You can just ballistically ask all the questions you want to. And that also gives a very good impression about your thought process. Because one thing that I personally feel and I've experienced is that it's not what they are looking for the diagnosis exactly, it's your thought process as well, particularly in those cases where history taking and explaining that diagnosis or differentials to the patient is a task, because what they're looking for is how did you included or excluded a few differentials by asking all the relevant questions that reflects your mind process, and that becomes much more easier if you have a few mnemonics for some common problems that come across prepared already. And then the other thing is crisis management. What so happens sometimes, you read a scenario outside, you're pretty confident. Yes, I know it could be either this and this and this and this and this. You go inside. The role player sometimes tricks you, or you sometimes get caught in the thought of a previous station or something like that. In a minute or two, if you're not anywhere near to what your plan was, you start falling apart. Then you just start panicking, and then you just start saying, okay, what I'm going to do, how's going to happen, oh, this case is definitely I'm going to flunk this case. Don't think that way. There's always a time to recover, to come back. Give it a second. Even if you give a pause in asking questions, even if you have to take 30 or 40 seconds, take a step back, recollect your thoughts, and then ask questions again, okay, in a different dimension. It's not that you have lost the case. It's never expected, I think, out of you that you just go and just very professionally, like a computer generated questions, you are asking things, then what would be the point of exam? So always prepare yourself for crisis, because that is something you might experience either because of lack of time, either because of not very well handled case previously in a previous station. You might think that you haven't done, you would have done a better job or so. So there's always a point of crisis management, and that really goes along with. Okay, so that's pretty much it about the general approach. Okay, So I'm here to discuss our scenario. So if I read it for you, you are in a GP setting, pretty much already told, where Peter, 65 years of age, presented with complaints of having pain in both of his legs for quite a while, not relieved by simple analgesia, which was available at home. Peter is known diabetic, hypertensive, with poor control of his medical conditions, had recent review of his medications by the specialist as well. He is a chronic smoker for the past 15 years. We have here a picture of Peter's legs, supposedly, and our tasks are to take detailed or relevant history from the patient and discuss the most probable diagnosis with him. Now, here comes all those points that I discussed in the previous slide could be applied here. So whatever the information has been provided already, a male, 65 years of age, something going on for quite a while, not acute, which is not relieved by simple analgesia. Okay, something might be serious. He has a couple of risk factors of diabetes, hypertension, has poor control, but he has a review of his medications by the specialist. Okay, so something might have been addressed about it. Plus, he's a smoker for the past 15 years. So if anyone could tell me what, again, the possible in the 2 minutes thinking time, that precious 2 minutes, what things might come to your mind? Okay, I think it might be either 3 or 4 possible.
Drug allergy. Can be
Okay,
drug
drug-
allergy.
Okay, all right. Drug allergy, all right. Anything?
Peripheral vascular disease.
Why not?
Good,
Peripheral
good
vascular
point.
disease, very good. Any other thing?
DVT, cellulitis,
Yes,
Cellulitis,
neurogenic.
yes, that's very good. So that's a very good actually differentials. So one of you mentioned about drug allergy, something again which has been going on for a while, plus these risk factors. Drug allergy should be in a differential, why not? But it should not be on our topmost differentials. The most
That's true.
critical of the thing would be categorize your differentials according to the severity and the presentation of the problem. All right, as it pinpointed, so we have to act fast, so we have to act wisely. We picked out our own case out of it, and then we devised a few differentials. Now let's fire away the questions. Okay, so first of all, 2 minutes of brainstorming. That was the part of brainstorming.
That was the differential workup that we were talking about. Like come up with a broad differential, just reading the scenario. Excellent.
Yes.
Got you.
So just scrutinize yourself, get the information through a sieve, highlight the points, and yes, I have come up with this and this and this. So the important things I need to cover in my history taking should be this and this and this and this. All right. Okay. So probable diagnosis for the presenting complaint. Presenting complaint was leg pain. It could go anywhere. All right. That was the complaint of the patient. So diagnosis here most likely seems to be a vasculopathy. It could be any form of arterial, it could be venous, it could be some lymphatic related, why not? Then again, skin or dermatology should be considered as a part of differential, but topping it up with the most probable one. All right. Okay. Now differentials. Now here comes the role of the mnemonics. Okay, I prepared, if a patient presented with this and this, I should at least cover this much of the differential. So if you have a mnemonic prepared, that would in fact, additionally save you another 20-25 seconds in your 2 minutes of precious thinking time. And then you can be more constructed and well organized once you enter the room. I have put it up according to the mnemonic, but yes, as I mentioned, try to prioritize your differentials according to the scenario, which is most relevant, should come at the top. So with the mnemonic L, we know something related to lymphatics should be in our mind. There should be some venous problems going on, as a few of you mentioned the differentials. Then arterial insufficiency, the topmost one for us. There might be some neurological problems and some skin related issues as well. So what we can do in our history is that we go inside, we do the ICCS strategy, as Dr. Rizwan told, start up with the open-ended question. What all this does is that would make the patient more comfortable. It would give an image that we are more empathetic about it, and we let the patient speak, okay, and then we can agree on a lot of things that patient might say. Then is the time to load our guns and then start firing away the questions to rule out the differential, so that in a better position at the end, when we have to counsel the patient or tell him the diagnosis, we can, with a lot of good reasons, that were explored in the history tell the patient that yes, the most probable thing that we were thinking about you is this, based on the problems you are experiencing. Why not the others? Because you don't have this and this and this and this. So I would rather be more focused on this thing which is going on. So that would give a very generalized holistic approach, and the patient would be, or the role player would be more satisfied that, okay, yeah, the doctor was just actually listening to me, and he just came up with, he tried to explain me as well, so that you won't rush your time. You would give full attention to the role play, not just asking the questions, because that would just squeeze out the element of empathy, which is very important in conditions which are chronically happening to the patient because they're quite frustrated about it. All right. So the critical errors here would, what would be for me is not considering arterial insufficiency as the most workable diagnosis based on the background that was provided, not identifying and addressing the risk factors involved. Just telling the patient that, okay, you are having this condition A, that's fine. You explain it very well, but do let the patient know as well what led to this problem as well, so that in the future, those risk factors could be addressed and patient does not present with another episode in the very near future time. So that is also, I think, is a part, very important part of discussing our diagnosis, or whenever you have to mention the risk factors or counsel a patient about a medical condition. That's very important because they should know, okay, this thing happened because of these small problems. So I should address these as well along with the acute problem. And obviously we have to refer the patient to the specialist, start up the workup and the management, and make the patient's life easier. All right. Okay. So Dr. Zwan, do we have enough time to discuss the other case as well?
Okay, we can quickly do that.
Okay. All right. So that's the scenario number 2. Jenny, who is 40 years, known patient of yours, presented to your practice for her general health checkup. She states that recently she feels more tired than usual, has gained unexplained weight, and is having constipation as well. Jenny is a school teacher who enjoys her job and has a happy life at home. She otherwise takes good care of her health as well. So again, the tasks are to take a detailed history from Jenny. Now this time they have mentioned specifically, so we can address, we can go into detail. We can do all that detailed Socrates and take all the relevant medical and social and psychological, not psychological really, if it does not point to history. And then we can discuss the most probable diagnosis and differentials with her. Now here the task is to discuss the diagnosis along with the differential with her. So that even makes it more important to take a detailed, very comprehensive history, because at the end, when we have to discuss what we are thinking, we have to tell her why we are thinking. And these differentials, why they are not at our topmost priority at the moment. Okay. So again, 2 minutes of brainstorming, 2 minutes thinking time is really, really important, because we have to devise our entire plan according to it, because based on the features that were presented. So the probable diagnosis with the presenting complaint. So the presenting complaint here was fatigue. She was tired. She has a cluster of symptoms as well. What could be the possible things that could come to our mind? If anyone could volunteer.
Could be endocrinological problems.
Why not?
Hypothyroid.
Very
Could
nice.
be something related to hematological issues like
Why not?
hemochromatosis
Yes.
or that stuff. And then in a female case, I would definitely rule out the ovarian cancers and the womb cancers in this particular case.
That should be considered as well. So you came up with a couple of differentials just based on the few complaints that were mentioned. Again, we start up with the very obvious open-ended questions after making sure the ICS strategy has been done. We start up with the open-ended question, let the patient speak. She might add up a few more symptoms or at least a detail of the symptoms that she has told. And then we can make our differentials a bit longer, or we can have to change it. We can do that accordingly. So here the diagnosis most likely turned out to be hypothyroidism for this patient. And the differentials, I know you must, majority of you might be aware, this is a very, very common mnemonic. Again, if we have this mnemonic in our mind, so we can ask a few questions, even if we are blank, we have 2 or 3 differentials definitely coming up to our mind, and we can speak about that. So we have to discuss the diagnosis here. After a detailed history, that was the task. So always discuss the diagnosis with the 5C strategy. That is, what is the condition? try to avoid very technical terminology, be very basic in general. Try to practice that as well. Secondly, comment on the commonality. That would again ease off the pressure from the patient that, okay, this is something very rare, something very unusual has happened to me. Talk about the commonality. What are the clinical features? How has the patient presented? The disease usually presents a similar way. What are the possible complications she might expect out of? So that would do a very good strategy for counseling as well as discussing the full case scenario.
Excellent. Thank you
so
very much for that, Dr. Hira. That was excellent. Now, does anybody have any questions before we start peeling away?
Hello, Dr. Rizan. I just had one question.
Yes, please.
Regarding the scenario 1, here this task is just the relevant history and discuss the probable differentials and diagnosis and differential diagnosis.
Yeah.
So how will we end the case here? Because we don't need to explain
That's
the
a very good point.
management.
Dr. Hira, would you like to turn off your slide share so I can just bring up my slides again?
Yeah.
Please. Good. So let's start. So let's go back in again. So are you talking about that long-winded approach, which I did?
No, in the scenario 1, which Dr. Hira did, just as an example.
Dr. Hira's scenario.
Yeah.
All right. So Dr. Hira, sorry, I misunderstood. I thought you were talking about
Right.
once the scenario that I was doing. Dr. Hira, would you like to answer this question? The question is that how would you end the scenario at the end of completing the task? Is that right?
Yes.
Yes.
Sorry, I couldn't get the question right. How would you end a scenario if the task?
The task here is a relevant history. We take the history and then discuss the probable diagnosis. We come to a diagnosis. So we tell the patient that this is probably arterial peripheral vascular disease, and it could be due to the chronic smoking and all these. But how do we end it?
So yes, I will answer this question. Actually, you always end with this thing which I say. Whenever you're ending any session, gosh, I'm getting a lot of noise. Gosh, can you turn yourself out to mute, please? Can you please turn yourself out to mute? There was a large hissing noise which just completely ruined the experience for everyone. So whenever you're ending any scenario, can you please end the scenario with squid approach? So summarize what you've just established. And if you've got 30 seconds left, so like in summary, look, given your risk factors. So one of the things which I still remember, I used to work as an intern. One of the orthopedic surgeons said to me, whenever you're giving the diagnosis or that final open-ended approach to the patient in terms of their workup, say that based on the history and examination, if you've done the examination, or based on the history and crucial findings on the history, I think you've got the arterial insufficiency. I think you've got cellulitis. But the other things you consider could be vascular insufficiency, like venous insufficiency or cellulitis. Now, do you understand what I'm trying to explain? So you just, you try to tease that information out. And finally, you said, I will give you some more information about the condition. I know it's a lot of information for you. It might be new. You might not have heard about it before, and you can think about it and come back to me. In the meantime, if the swelling, the pain, the redness gets worse, can you please come back to me? So that's what I'm referring to as squid approach: summary, questions, information, and danger signs. Does it make sense?
Oh, yes. Thank you. Because we don't need to tell the management, so we will not get anything in the management.
You just reiterate the positive points that you've established. Okay. Is that right, Dr. Hira?
Yes, that's pretty much I have a different approach. I usually name them as 4 or 5 hours, but it's the same thing as you told.
Okay. No, tell us something about your approach as well. I think it'll create a bit of a
it's the same thing. It's just everything starts with R, that we provide them a reading material. We tell them the red flags. We ask them to review, that is for follow-up. And then we tell them the reasons why we thought of this. So it's pretty much the same thing, but with different words.
All right. Okay. Well, thank you, everyone. Thank you for coming in and joining us for about an hour. I hope that you've been able to sort of learn and take those telltale signs that we've all discussed and talked about.
Just one thing, Dr. Zwan.
Yeah.
I'm not sure if you are able to access the messages, but some of them just missed the first initial half of the session today. So if you have recorded from start, they want you to upload the video so that you could just catch up on.
Sure. Look, I'll look into that because I think we did not record the first half of the session.
Yes,
I'm
yes.
sorry, I completely forgot that. But anyway, I'll do something about it and I'll upload it on our YouTube channel. So try to access the video. I'll try and make up for the first half of the session by recording it myself and upload in the YouTube's video in the next couple of hours. So our YouTube channel is youtube.com/emergency focus, something like that. So emergency focus, you just set it out and just settle it. Any other questions somebody may have? No.
Let me read the message as well if there is something.
Can I ask a question about the first case? I recall that Dr. Wiswan would prescribe analgesics upon seeing the patient first, since she is obviously in pain. But would you also ask first about any food or drug allergy just to play safe?
Absolutely. So that's something that we've already covered as a part of leading questions, that what is your past medical history and what regular medications do you have any allergies? So once you've excluded the allergies there, you don't have to come and explore the allergies unless and until, there's something which is mentioned that, I am allergic to penicillin, and you're trying to give another medication. Have you had ceftriaxone before? Because there is cross sensitivity with ceftriaxone to about 15% of the cases. Can you take clindamycin? Because that's what therapeutic guidelines suggest for cellulitis and abscess, somebody got penicillin allergy. So there can be different ways of addressing the issue if there is a positive allergy, but we've already asked that question as a part of our leading questions.
All right, okay. Thank you very much.
Perfect. Thank you. And I think that's about it, really. Okay, I'll let you guys go. Enjoy the rest of your Sunday. Thank you.
All right. Thank you very much.